everybody, thank you so much for joining us. We have, we have pulled strings today to get to today. I am so honored to have Dr. Amy Talbot on, and I learned from her and about her at Feeding Matters. She came on to the ARFID, the Psychology of Eating Summit that was just orchestrated and hosted. I guess it was live in September, and it was available for like 30, 45 days online.
I think it's still available now.
Yes. Folks, you need to go
but maybe not when this goes live.
Oh, that's okay. They sometimes do like snippets or have videos. So check out the ARFID PFD page or the learning page on Feeding Matters. I'll see if I can tag that in the show notes. Feeding Matters, we love you. But that's where I learned about you, and then I was like, maybe she'll say yes to this random email when I emailed you, and you did, and I was so excited. So, hi, thank you for coming on.
Thanks, Michelle. That's a lovely welcome. I was very pleased to receive your invitation, actually. I shared it with our speech pathology team, and they were very excited that I had been invited to come on your podcast.
Yay! Oh, I'm over here like fangirling. So, like, also, my children have two questions, and I'm sure you get asked this all the time. But does your toilet spin in the opposite direction?
Oh, I don't think that I've ever actually checked. But also, I haven't been to the US, so I'm not sure what direction your toilet spins in.
Our toilet. I'm asking my husband because now I don't know.
It's the opposite direction of Australia's.
My husband says it spins in the opposite direction, and my 12-year-old's going to go flush to verify which direction it goes. I promise this is a scholarly podcast, but right now we have potty issues.
Spins to the right.
Spins to the right. So our toilet spins to the right.
I think ours does go to the left, but I'm not 100% sure. I feel like I would have to check.
Okay. My husband's and his little engineering self is over there like, yes. But okay, well, other than that, the other question is what time? It's 5:14 Eastern Standard Time. What time on Thursday, October 2nd. So what time is it for you now?
Yes, so it's 7:14 a.m. on Friday, the 3rd of October.
That's so cool. It's like I'm talking into the future. That's amazing.
I love that. Love that idea of talking into the future.
It's a good one. Tell us about you. I know that you're the director of your clinic and that you focus on ARFID and feeding. And this is huge because here in the States, we don't have access to a lot of psychologists that work in that area. But like, how in the world did you land here at like a dream job?
Yeah, well, so in Australia, we also don't have a lot of psychologists who work in ARFID and feeding.
Yeah.
I think my path is maybe happenstance in that by sheer luck, I ended up in this space, or due to exposure and meeting people with lived experience and the opportunities that I had, I ended up here. So, I think in the early stages of my training as a psychologist, I was interested in eating disorders. More generally, so more like anorexia, bulimia, nervosa, these sorts of eating disorders. And so I did my early research in that area. And as part of my clinical doctorate, I did clinical training in that area. And prior to that, I'd worked predominantly with young people who are autistic. So I had an interest in neurodiversity and an interest in eating disorders, which actually at the time was considered quite unusual. The majority of people in my profession, these were two areas that people didn't really want to work in and were quite surprised when you wanted to work in them. And they were very surprised if you wanted to work in both of them. So, my colleagues in the autism space predominantly didn't work in feeding and eating disorders. And my colleagues in the eating disorder space didn't really do a lot of work in neurodiversity. That's changed quite a lot since it's become more apparent about the overlap between the two. So it's been fantastic to see more people kind of coming into this space over time. But essentially, I worked in an eating disorder clinic, but I was also pediatrically trained, which was quite unusual. Most people who work in eating disorder clinics work with adolescents or adults, and not so much with young people and children. And so our clinic was involved in a research trial for Maudsley family based treatment for anorexia nervosa. And as part of the research trial, every person who was referred to the clinic who was under 18 years of age, they were assessed by one person to determine whether they would be suitable for the trial or not. And for whatever reason at that time, this was actually before ARFID was added into the DSM. So ARFID was added into the DSM, I think, back in 2013 or 2015. So it's been about a decade. And just before that, they had all these people coming through this clinic that were assessed. They were under 18 years of age. They had some sort of eating or feeding related concern, but it wasn't anorexia nervosa, and it wasn't something that we had really worked with before or seen before. But many of them were quite young. And because I was the only pediatric trained clinician in the service, all of them got allocated to me. And so I ended up with,
You.
yes, I ended up with this caseload of all these clients that have what we now call ARFID. And I didn't really know what I was doing or how I could help them. And so I really tried to listen and understand what their experience was and try to use the skills I did have, the more general skills in understanding people and understanding mental health, to try and be helpful to them. And one of the things that I did is that, as you would probably be aware, speech pathologists and OTs and dietitians have been working in pediatric feeding for a long time, much longer than when I came into this space, and much longer than ARFID has been in the DSM, or Diagnostic and Statistical Manual. So we use DSM in Australia, but I think in the US you might use ICD more frequently.
Um, so here in the States, I can give a diagnosis of pediatric feeding disorder, acute or chronic. That's within my scope of practice, but I cannot diagnose ARFID. That is
Yes.
outside. So, folks, if you are listening, and trust me, when I first started out, I was told by other therapists, oh yeah, you can diagnose ARFID. We cannot, you cannot. It's outside of our scope of practice. It is in the DSM-5 catalog. And what I find is I'll get the kids sent to me because picky eating or failure to thrive. And it's really cool to work with the pediatricians and then build a trusting relationship, because then the failure to thrive referrals drop and
Yes.
I actually see PFD on the script and I'm like, yes, we've made a difference. But they come to me and I'm like, oh, this is not pediatric feeding disorder.
Yes.
You need to go see a psychologist. And
Yes.
that's, but then we don't have a lot of places to refer. So it typically goes that far. And then it's like, very
Yes.
technical.
Absolutely.
Yeah.
Absolutely. And I think we're going to talk about that today, how to find psychologists to refer to and how to build networks. But essentially, because speech pathologists and OTs and dietitians had been working in a pediatric feeding space for a long time, and psychologists really hadn't worked very much in that space at all, I went and learnt from other disciplines because I needed something to offer these clients that I was working with at the clinic. And it was fantastic. I went and learnt from all these different disciplines, and got to understand their approach to feeding, and what we could draw from that and what we could understand from that that might be helpful in supporting the clients that I was working with at the clinic. And I think that's kind of how I started out in this space over a decade ago now, um, is just through necessity of wanting to really help the people that I was working with and not really being sure about how to go about that. And now I help other people, other psychologists, to learn about how to work in this space, so that we can improve the workforce and the accessibility for our clients.
Yes. Um, interprofessional education.
Yes.
I thought I was doing okay as a speech therapist, and then I met Paul Tardy, who will go down as one of my favorite occupational therapists, and he like shook my foundation and helped rebuild it because it was just so profound. um, I don't know how much interprofessional education is taught in Australia, but here in the States, like within the training for speech therapy, we might have one or two simulations in like the course of grad school, and that's really it. So unless a student clinician experiences it in a like in a
Yeah.
clinical, it's scant. I mean, how does that look for y'all?
Yeah, unfortunately, it's pretty similar in Australia. There's not a lot of focus on interdisciplinary education. But one of the best things I think about working in this space is that it's really given me the opportunity to expand my horizon
Yeah,
and what we call it scope of awareness.
scope of
That
awareness.
I just am I know so much more about things than I would have known and understand more holistically things that I just wouldn't have understood if I hadn't worked so closely with other people from different disciplines. And I'm really privileged to be in a position at our clinic where we work closely together all the time. So every day I'm learning from people from different disciplines, from speech pathologists, from dietitians, from our pediatrician. There's just And I think that the team would say this as well, that we've all benefited from the richness of those conversations in the quality of the care that we provide to our clients and how we understand more holistically what might be happening for them.
Yes, that's you're only as strong as the team that you build. We
Yeah.
can't practice in a silo. Yes. Oh, you are exactly what my heart needed at the end of a Thursday. This is phenomenal. But okay, let's start at the top. Can you kind of explain to those that are listening what is the difference between a pediatric feeding disorder and ARFID?
Yeah. So I think I mentioned to you before we joined that there's some differences of opinion about this
Yeah,
across the
there is.
world. Um, so maybe if I start with what I understand the kind of position is it seems to be upheld in the US, and then I can explain what my position is and how we approach it in Australia, which is slightly different. Um, some of the, I think, quite established people in the feeding space, and when I've spoken to Feeding Matters or when I did my presentation for them, they're quite clear about how they kind of see the differentiation between the two presentations. And so, from that perspective, the perspective seems to be that if you have onset in childhood or very early, if there are skills related concerns, such as oral motor skills challenges, if there are underlying medical concerns, then it has to be PFD rather than ARFID. And therefore, individuals are classified as having ARFID if it's more of a mental health condition, in terms of that there's underlying anxiety driving it around fear of choking or vomiting or some of these other concerns. Then it would be classified as ARFID because it fits in the mental health domain, and pediatric feeding is kind of outside of the mental health domain. So that's my understanding of how it's being spoken about by very well known and respected professionals who are talking about this in a regular capacity. I see it a little bit differently, and we've talked about this quite a lot at our clinic. Um, and there was a paper, which I might send you in case the listeners are interested, looking at the overlap between pediatric feeding disorder and ARFID, and the idea that a lot of people will actually meet criteria for both, rather than having kind of one or the other. And I do think there's a lot of overlap between ARFID and PFD. So it looks like we're on the same page there. Um, so often in our clinic, we do an assessment for both and then say we feel like this one, even if they meet criteria for both, we might say we feel like this one is a better representation um, for this client and understanding what is happening for this client for these reasons. And so, in that regard, we sometimes do kind of lean into that. If there's a lot of medical or skills related concerns, then we might be more likely to say it's more likely that PFD is the best fit rather than ARFID. However, there are some challenges, I think. One is we also work with adult clients, and adults who have slightly later onset or significant exacerbation of their feeding related concerns later in life. Maybe they didn't have a feeding disorder earlier, but they had some vulnerability. Maybe they had a little bit more of a restricted range than other people, or were a little bit more sensitive to sensory properties of food than others. And then maybe for whatever reason something happens along the way and it becomes more significant for them, you can't diagnose them with PFD. uh, a No adult wants to be told they have a pediatric feeding disorder. um, and B, they don't meet the criteria because they didn't really have onset in their childhood. It's more that like they've had this kind of condition more significantly in their adulthood. And some of these people do have quite significant medical conditions, for example. Maybe they have gastroenterological concerns. That's a really common one, and they need to fit somewhere in the spectrum of how we understand feeding related concerns. And they most likely fit best within the ARFID category, but they probably look quite similar in some ways to some of the children that we're saying, well, they definitely have PFD and not ARFID. And so that doesn't quite make sense to me to distinguish it in that way.
It begs the question, are we going to have an additional diagnosis? Like, is, AFD a potential on the horizon? Because there's um uh Marcia Duncline has been interviewing a lot of autistic teens, and they're still dealing with and working through a PFD and or ARFID
Yes.
or a combo of the both. But it's just like in the framework of like special education, you can get pediatric feeding disorder birth to 3 and early intervention, but that's not going to stop when you turn 3 and go to the public
That's
schools,
right.
and why you have to have it. But it's not going to magically turn off when you're 17 if you've engaged with this,
Yes.
and you're turning 18. Is 18 the legal adult age in Australia?
Yes, it is.
Okay.
It
All
is.
right. I was
Yes.
thinking out of context. That might not be the right year, but yeah. I have to be honest. I thoroughly appreciate the resources. So, folks, the resources that she was referencing on the Feeding Matters webpage, they actually have really cool charts that you can go and see. So,
Yes.
it's the PFD and ARFID overlap. And if you're a charty, like if you like the organization visual graphics, like myself, it's beautiful. You can print them. I have shared them with caregivers. So then they're walking out the door with the tool. But what I have seen happen time and again is I get a referral and we suspect ARFID, but, but I can't give that diagnosis. And there is a significant psychosocial component, but what drove it all along was the medical.
Yes.
And so then we get the medical address, I'm running a special right now on enlarged tonsils and adenoids causing disruption in the oropharyngeal stage of dysphagia. And so they're avoiding certain foods so that it doesn't hit the tissue mass and it's easier
Yes.
to chew through, right? But we get that addressed, or we get insert GI component address, whatever the medical is. But it's as if, and the way I explain it to caregivers, the child has to relearn their
Yes.
relationship with food. And we've addressed all of this. We've worked through feeding skills. Maybe they avoided learning to eat with utensils because they just wanted finger foods because finger foods felt safe. So
Yes.
we've hit 3 of the 4. But what I'm left with was, did this pediatric feeding disorder drive an ARFID diagnosis? Am I nuts? Do you see that?
Yes, absolutely. Because in that case that you described, what is happening is this child is being traumatized over and over and over in the
Yes.
context of their eating experience because of their medical condition and their pain. And just removing that or treating that doesn't take away all that trauma learning that they've
Yes.
had. as you said, they need to relearn what is it, and we know that people like learning doesn't happen quickly necessarily. And
Correct.
so you can have one or two experiences that are not painful, but that doesn't negate all of your previous learning around all the pain that you've experienced or all the
Yeah.
discomfort. You just anticipate that it's still going to be there at some point and you still need to be apprehensive. So it takes quite a while to unlearn that history of association between eating and pain.
It's trauma. You hit it on the head. I have tiny ears present, but I have old trauma from 15, 16 years ago. And you have to relearn the world outside of that trauma. And that
Yes.
takes time. When it comes to treatment, what I see on social media is that folks want to jump straight to treatment and how to fix it. And it looks flashy and it looks glamorous. But I'm like, it takes time to heal.
It does. It's slow
Yeah.
and small steps.
Yes. Very much. Very, very much. And we have to honor that, you know?
Yes.
Ugh.
Yes.
Okay. So, within the framework of your screening, to get to the point where you're doing an assessment to delineate what is this? Do you have like set screening tools that you use?
Yeah, so we do use the party, which is a semi-structured interview diagnostic tool for ARFID. It stands for the PCAR, ARFID, and rumination disorder interview. Um, so that's a mouthful.
I know.
But
I'm thinking, do you do that much with rumination as well?
oh, we do work with rumination in our clinic. Yeah.
Okay,
Um,
wait. Can you for folks that aren't familiar with rumination, can you describe what that is?
Yeah, so in simple terms, I guess it's the regurgitation of food through um, what's through a process related to you eat the food and then it comes back up. Not so much like reflux or like um, like vomit, but more like unprocessed food is regurgitated. There's some kind of variation in what that might look like depending on how long afterwards the regurgitation is occurring. Um, but it's often involuntary. So
Yeah.
it's the muscle is kind of regurgitating the food, and it makes it really challenging for people to sustain an adequate diet and to eat regularly.
I have worked with that twice with little ones that had a pediatric feeding disorder per se, and the diagnosis came with, but in both cases, there was significant neglect and trauma and food scarcity in their backgrounds. And so, one of them, it was back in South Carolina, one of them came with their um, guardian ad litem, court appointed safety person, for lack of a better phrase. And it was how they felt full as they would regurgitate it and come back up. So when I see rumination or get concerns for rumination, I think of like fear of not having enough food. We went down a rabbit hole, but like, am I wrong for like concerning for that? Like, what if a caregiver says that during the eval, what should the speech therapist be thinking?
Yeah, so I think it's still not very well understood exactly what causes rumination disorder. And we've seen in our clinic onset in adolescence and adulthood as well. So I think it's
Okay.
not always related to food scarcity and trauma, but it is often a very interesting presentation from a psychological perspective in that there often are other comorbidities or other challenges that individuals are experiencing. um, Sometimes there are underlying pre-existing or pre-occurring kind of medical conditions as well. um, it might be onset by reflux and then it goes into rumination disorder, or it might be onset by a stomach bug, for example, and then it seems to go on to rumination disorder. So it's not always trauma and food scarcity, but definitely having a more broad psychological screen in the context of the presentation of rumination disorder is important to understand what other factors might be relevant there.
Okay, so my note to self is if a caregiver brings it up, flag it, phone a friend.
Yes, exactly, exactly.
I appreciate that. Also, you said stomach bug, and I legit spent 2 days home this week on the couch because we had a stomach bug go through the clinic. And
Oh,
like,
no.
dude, I drank veggie broth for 2 days straight. And so I was
And you
like,
know what? I saw the visceral trauma response, when I mentioned stomach bug, and
on my
it
face.
doesn't take that long, right? It doesn't take that long to have a trauma response.
No, it does
Yeah.
not. I was like, oh God, no more ginger ale. I hate ginger ale, but like, yes. Okay. So to get us back on track, because that
Yes.
was a very good deviation, lots of information. You were talking about the screening tools that you use.
Yes. So we use the party, as I mentioned, which is a semi-structured, clinical interview. We also have added some of our own questions to just flesh out, I guess, not so much the diagnosis, but more the clinical information that we need to determine how to support the family or the adult who's presenting. There's some good screening tools available as well. If you know that speech pathologists could use, there's one called the NIAS, which I can give you to upload for people to
Yes.
download. It's just a 9-item ARFID scale. That's what it stands for. So it's only 9 questions, and it's a screening tool that can be used by other professionals to determine whether or not further assessment for ARFID might be required.
Yes, please
So
share.
that one could be good. And but we mostly rely on quite a comprehensive clinical interview and a number of observational assessments in order to form like a holistic picture of what's going on. And then we kind of debate amongst the team what we think is the best explanation based on where we think the targets of intervention are initially, and what's going to make the most sense when explaining it to the client or the family as well.
Nice. Okay. So a tiny human, if they get accepted, I'm assuming that's like, is that like y'all decide to pick them up? What happens next? Like, what does the process look like from there?
Yeah. Do you mean starting with the assessment
Yes, ma'am.
or after the assessment?
Like you go through the screening and then you go into an assessment. Is that how this works? Because we don't
Yes,
get a chance
that's right.
to screen. Like when here in the States, they might get screened at the pediatrician's office, but it's basically just go see the speech therapist for an eval. So we don't Feeding Matters has the screening tool, and I know some school districts have started using that embedded in, and some early intervention systems have started embedding that in. But then it just goes straight to like the assessment.
Yeah.
It's yes,
That's mostly what happens for us too. The screening would be happening with health professionals that already have concerns, mostly, I think, about feeding, and then they would be referred, or people are self-identifying that they have concerns and then referring to the service. And so we do like a phone screen um, to make sure that they're suitable for the service and that we're recommending the right services to them before they connect with us. And then, depending on their needs, if we determine that their needs are maybe more complex, then we would do a full interdisciplinary assessment. So that involves a clinical interview, which would usually be done by the psychologist, and that information is then shared with the whole team. So they just have to do one interview instead of, when I guess you see various different health professionals at different services, you have to repeat the same clinical history again and again and again. So we don't do that. We send them some questionnaires in advance and they put in a bunch of information. And that way we can focus on the things that are most relevant to them, but also we can check if things get in the screening that we send them, if things get flagged that we think, oh, this is more like speech related, the psychologist can check with the speech therapist, what do you want me to ask about this? What else do you want to know about this? And so then the psychologist will go in. Um, because we use that material to make a diagnosis of ARFID, it's usually done by the psychologist so that they can then make the diagnosis if that's what's required. And after the clinical interview, they then do a series of what we call observational tasks. So they would do an oral motor screen with and without food that's conducted by a speech pathologist. They would do a sensory profile and sensory screen. They would do a couple of nutritional tasks that are reviewed by our dietitian. So they do a food diary and a food list. And they also do a meal observation video. So they do a video of what their meals look like at home with some instructions. And we do an eval on the video about like relationship and environmental factors that might be contributing to feeding. And then we all meet together and talk about the outcomes from the assessment, develop a interdisciplinary formulation. So a formulation is like a story that explains how we understand what is happening for the client. Then we agree on the diagnosis and the recommendations, and we give the feedback to the family.
Nice. What is your timeline from start to finish?
So max 4 weeks.
Oh, that's lovely. How long is the wait list though? Like to actually for a patient, do you call them clients, patients?
Oh,
It,
either is fine. Yeah.
I was say same here. I've seen it. It depends on like what setting as to what the tiny humans are called.
Yes.
Either way, the tiny humans. But how long is the wait list for services, or is that unique to what where you are geographically?
So we accept referrals from all over Australia. Because there are very few interdisciplinary feeding services in Australia, we also have accepted referrals internationally. So we have some clients in Europe and some in Asia, uh, because they also have limited feeding services available. And clients can be referred to our service for the assessment alone. So we offer the interdisciplinary assessment as a standalone service. And then they can either take our recommendations and access therapeutic services within our clinic, or they can access some of the therapeutic services within our clinic and some of them locally. Or we can provide like a coordination of care role. So they can take the recommendations back to their local services, and we will liaise and provide oversight of their treatment in their local like space. Um,
Yeah.
yeah, so the wait time actually isn't too long. If the wait time becomes long, then usually what we do is we would assess whether or not there's value in getting them started, say with a dietitian, for example, for some preliminary support while they're waiting for the full assessment. So we don't like people to have to wait too long for the assessment, because obviously the nature of feeding concerns means that things can deteriorate quite quickly.
Yes.
So
And
we want to minimize wait times. The other thing that we do to help people get started as soon as possible is while the assessment is happening, parents normally have a support education session. Where we provide some kind of preliminary information about feeding, about how to create a safe environment at home that they can start implementing before the assessment is actually finished.
I know personally over the course of my career, I've had 3 month wait length time to 18 months. It, and that's just to see me in whichever setting. Um, the good Lord tends to put me. So there's that. But when you're looking at treatment, do you often prescribe medication? Like I'm just trying I see a lot of little ones that need ARFID or periactin for like appetite stimulation. And
Yeah.
but that's normally driven by like a volume, like we just have such limited volume, but also is there underlying constipation and motility
Yes.
issues, and that tends to go hand in hand. And we had I had the joy of interviewing Dr. Richard Noel back a couple months ago, and when he came on, he was like, from a GI perspective, we'd prefer Periact and Ariped first, but for some cases, we'll switch over to Remeron. Am I saying that correctly? Yep. And he's like, but he goes, that's often used more for like anxiety. He goes, so GI tends not to start there, but it does have the effect of it makes you poop faster and it makes you
Yeah.
eat more. But yeah, I just kind of wonder what that treatment looks like.
Yeah. So I'm not as involved in the medical side of it. Our pediatrician is more involved in that. So we don't generally recommend medication as a first, like as a starting point, unless there's very severe anxiety that might need to be managed. Um, and
which is
then usually
valid.
we would recommend like an SSRI, so an anxiety-based medication. And sometimes we would recommend, it depends on kind of the preferences. If we can get supplementation as opposed to medication, we might try that first. So if a
Like,
child was able to accept like Ensure, Pediasure,
yep.
um,
Kate
we would try
Farms.
that first. Yeah.
Have you tried Kate Farms yet? Do you have
No.
Kate Farms? Oh, Kate Farms is, plant-based, and it's all natural, and it's a really good their chocolate is I tasted to kids, obviously
Ah,
not after they'd
okay.
had it, but here in the States, insurance will pay for it, and you can either have it orally or enteral, and so I have a lot of kids that go on Pediasure, and then the sugars jack them up,
Yeah.
literally, and then back them up, but Kate Farms or sorry, this was a conversation I had with a mommy at
Yeah.
11 o'clock my time. Yes,
That's fantastic. I'll definitely look into that a little bit more.
I'll send you
Um,
the info.
and see what options we have in Australia or whether we can order them from the States, I suppose. Um, so yeah, we might use like Pediasure, softer things like Movicol, like
What is
some,
this?
do you have Movicol?
No, I don't know what this is.
So Movicol is a, like, it helps with bowel movements. It's like a more natural treatment for constipation.
Is it the little chocolate squares?
No, it's more like a drink.
Oh no, I don't know that one at all. Novacol. Okay.
So yeah, I guess we must have some differences in so yeah, we would try something if we quit something that's kind of soft on the system rather than medication as a starting point, some supplementation, definitely enteral feeding if that is preferred. Um, one of the things that I think has been challenging is we're quite pro enteral feeding. If that is something that families want to do, we think it gives people a break. It gives people a break from the intensity of all the meals. It allows them some space and time to focus on other things, to build relationships outside of meals, to be able to build their life outside of food. But sometimes it can be quite hard to advocate for enteral feeding when they can eat orally. That's one of the like challenges that we found as a team.
Um, I have a quote in my book, fed is fed is fed, whether it be like through an NG, orally, or a G or a J. Like, if we're not nourishing our bodies, then we're not set for healing. And I
Absolutely.
am, I am pro, let's get the tiny humans nourished and then towards healing, both spiritually, because I think that relationship piece is that's where I see God, right? You break bread with your family, you make memories here. There you move your spirit there and it's beautiful. How how do you guys as a team start them on that healing? Like as the psychologist, like what is your what does the intervention look like?
Yeah, so generally we usually recommend interdisciplinary intervention. So we usually recommending more than one person in the team. And then we obviously need to try and prioritize what families can manage. One of the things that we have found, which is quite challenging for our families, is families with feeding related concerns often have other concerns as well that they need to address. And so they're often already engaged with lots of health professionals, and adding a whole nother team of people on top in terms of feeding support can be very overwhelming and create a huge burden of therapy. So we're really careful not to do that. We look at what their current supports look like, how well engaged they are with their current supports, whether or not we can coordinate some of those current supports to what they're working on to facilitate the improvement in the feeding. So, if they already have an OT, for example, they don't have to be an OT that knows about feeding. But if they are skilled in sensory processing, support, and accommodation, then we might be talking about with the OT, well, these are the specific areas around sensory processing and accommodation that are directly impacting the food. Can you work on these things with the family so that there's a flow on effect to the food, for example?
Yeah.
Um, So we tried to kind of build in what they already have available, where they already have established relationships, because it's not just relationships within the family that are important, it's relationships with their healthcare team as well. So if they already have people that they trust, where the child has built a trusting relationship, then it can be faster. If we have to come in and build a trusting relationship, that takes time. And so we're definitely starting with really trying to build that sense of safety and relationship with the family and with the child, so that they know that that we are safe people that aren't going to be expecting them to do things that are traumatizing. Many of them have had traumatic experiences engaging with healthcare services, sometimes
Yes.
traumatic medical experiences. And
Yes.
so we need to, that's what they're bringing potentially to another healthcare service, is all this trauma related to healthcare services. So we really start very slowly in that regard, just helping to create safety, helping them to associate our clinic differently than other services that they might have been to, building on the safe relationships that they have, upskilling the parents, so that the parents can apply things in a space where the relationship is maybe already safe, making sure that we remove some of the pressures, hence the recommendation sometimes for NG feeding, so that the family can focus on the safety and the relationship, instead of having to be so worried about the food and focusing on the food right from the outset. So often we're not necessarily starting with the food, we're starting with all these other things that are important foundations for the
Yes.
food. Uh, but we might start with some of those early recommendations around medical support. So if there are problems with constipation or pain, or that has to be addressed first. You
Yes.
can't learn anything else while you continue to be in pain or
Correct.
discomfort associated with eating. Um, and we try to get some stability around physical health, whatever that looks like, whether that's through supplementation or enteral feeding, or giving recommendations around how to utilize foods that are already preferred and included to maximize nutritional outcomes. For example, we have lots of fortified cereals in Australia. So if the child already accepts, say, Milo cereal, which is one of the fortified cereals, um, Milo cereal is probably considered to be like a junk food, I suppose, if I can use that terminology.
How, I was
So,
going to say, how do I spell this word? Milo?
yes, Milo. So Milo cereal is kind of fortified with iron and some other things. So, and it's
It's got
chocolate flavored.
flavors on
Yeah.
it. That's our Wheaties.
So if kids already eat that, for example, then our dietitian might say, well, actually, you can serve this to them more often because it's actually fortified with these other nutrients. Even though parents might be getting messaging, I guess, from society or from that's not healthy, and so you shouldn't be giving them lots of that food. So we try really hard to help parents to understand the actual nutrient profile of what their children are intaking already, and help them to build the best diet from that. So, just very small changes in the early stage to get that physical stability around health, while mostly focusing on safety and establishing kind of regulation in the context of that trauma.
Okay, so very many clinical thoughts. I appreciate that you started this with focusing on safety within the healthcare team. Um, Folks, I had a real life example this morning. We sent a little one. We're pretty sure it's a chronic constipation issue, but we have a globus sensation when we swallow, so we have a complaint of food getting stuck here.
Mm,
So GI did the appropriate referral for a swallow study. Let's rule this out, and they went in for the swallow study, and the colleague SLP at the hospital that did it did not explain what she was doing, how
yeah.
she was prepping the foods. So the very few accepted foods that we were consuming were essentially violated. So we were down to 5 foods and 2 smoothies, and then you just violated the rules of the 3 foods by not explaining this. And
Yes.
and obviously the mother was gravely upset because that night the child refused to eat. But big picture, this brought back to me, I had made a video for the caregiver to play because I couldn't reach. I mean, we don't know who's going to be like the diagnostic SLP inpatient. I can't fathom what that caseload looks like. But I was like, play this for them so they can see it. And she told me the video was dismissed. But that puts it back on us as intra-professional practice. So SLPs, I'm looking over here because my microphone is sitting on the piano bench. But if you're in that setting, pause for 2 seconds. Our healthcare system is very fast, but pause for 2 seconds and seek to understand what the concerns are. Because yes, we're rapid fire trying to get a diagnostic assessment, but if we don't explain and violate, these kids will lose that. And when we don't have the option for enteral feeds, because that's poo-pooed upon for a lot of
Yeah,
cases, it's I, it's taken us time to grow back those previously accepted foods. Um,
absolutely,
so thank
absolutely.
you for
And so we
starting
do
with
harm,
the
right? If we're not
yeah.
careful and we don't think about the potential experience or implication of the interventions that we're doing medically.
Um, I find that when I do my feeding evals, I always say, well, I'm not sure if you can hear Waffles barking in the background. She is pro this recommendation, but I always say, bring me your favorite foods and let me, sorry, Waffles is the dog, guys. But like, that's a huge, we cannot violate the foods that they eat. What do y'all do after you focus on coaching for safety and then get to, like, when do y'all actually start introducing food into therapy? Because that can be hard.
Yes, absolutely. So I guess it depends what our evaluation indicates about what might be contributing to the young person's challenges with food. So, and it depends on what the specific goals are of the family and the young person. So, not everyone's goals are to introduce a whole bunch of new foods. Sometimes their goals are to have less stress around food at home, or to be able to eat when they go out. Or so it's not so much about having a whole bunch of foods. It's more about creating a relationship with food that is safe and can continue to develop over time. So um, if so sometimes obviously there are skills contributors, as you would know, oral motor skills contributors that need to be developed and worked on in order to help kids to be able to eat more foods. We might do skills-based sessions once that safety is established, and they're usually done by our speech pathologist. And we're in a very lucky position in that we have a full kitchen and dining in our clinic for therapy purposes. So we
That's
built a
amazing.
kitchen that's just like a home kitchen so that kids and families can actually get in there and do work with food in our kitchen, and explore foods and learn about foods and engage with foods, which is why it's so important that they feel safe in our clinic. So
Yeah,
sometimes we don't take them into the kitchen in the clinic, because just being in a kitchen is so overwhelming or so unsafe or so pressureful. And so it might be a long time before we even go into the clinic, into the kitchen. And sometimes that's all we do. We just visit the kitchen, and
but
maybe learn
that's
about the pots and
good.
pans that are in the kitchen, or and then we leave, and we do some other work in a therapy room instead. So we take it at the pace of the families. We do lots of different types of activities, some cooking, some like play-based activities. Sometimes we use my son, he's 5. When the speechy
Yes,
wants to try some new activities, she'll be like, "Can you bring Teddy?" And we'll see whether
what
he
is his
likes them.
name?
His name's Theodore. We call him Teddy.
That's my
Um,
bear. His name's
oh,
Theodore.
really?
We call him Bear. Yes. Theodore Alexander.
Um, so he'll come and try the new activities, and see whether he likes them and give feedback about whether they're fun or not. So that's a bit of fun. So we try to make it fun, child led.
Yeah.
I've had some when I've done some, I've had some fun doing some mixed texture experiments with kids when they're a bit more like further along. So I particularly like making fried rice because rice is often one of the things that kids can tolerate because it's plain. And so we can build on that by learning about lots of different types of foods and then asking them to make their own fried rice concoction. And then we cook it together and we might try it. I remember with one child, we tried putting seeds and things in it. So some really unusual foods like sesame seeds and pumpkin seeds. And we tested out, can you actually tell that there are seeds in there? Does it taste the same or different? Can you find the seeds? So
Yeah.
we tried a few different things like that. One time I tried to make an acai bowl with a child. And I thought that it was gonna be fun, but I couldn't get the acai to the right texture to make a bowl, so we had a blender, and I was like, "Let's just make like a smoothie."
Yeah.
And we had all these ingredients, and I let her pick, what is she gonna put in the blender to make the acai drink. And she put in a lot of different things, and it smelled terrible at the end. Like I was like, "This is so gross." I didn't say that, um, but she was able to drink the whole thing. I couldn't do it. I had to pour it down the sink.
I think the grossest thing I've ever taken for the team is one mommy wanted us to use McDonald's sweet and sour sauce as an
Mhm.
accepted condiment. And I was like, okay, please explain to me why this sauce. And she had
'Cause
five
it's the
girls.
best,
Oh,
right? It's
no,
the best.
that is no, it was her other 4 girls would eat that sauce, and when she was picking them up from school and going to cheerleading and ballet
Yeah,
and, like, all of the things, it made her life easier when she hit the drive-through,
yeah,
and they would always forget her other daughter's sauce, so if she ate this sauce, then they wouldn't have to stress about the
yes.
sauces on the way, and I'm like,
And this makes so much sense, right?
"This."
This is why we do family-directed goals.
Yes,
Yes.
like, as a clinician pre-children, didn't make sense. Me as a mom during cross country season, oh, she was on to something.
Yeah.
But, like, I don't like sweet and sour sauce from McDonald's, but I ate it.
Well, you
Oh,
did well. I like sweet and sour sauce, but I don't like pulp orange juice. And the one time we buy foods like to bring to the feeding sessions, and one time a different person from the staff bought the foods on the list, and they obviously didn't know that I don't like the pulp orange juice because the other one did know, and they would always buy the pulp free. And this one bought this orange juice full of pulp, and I was like, "Oh, I'm just gonna have to have this." And the kid thought it was the best. They loved it, which was fantastic, but I didn't.
I mean, sometimes I sit back and I'm like, oh, I see myself in this tiny human, right? And or my favorite is the caregivers want us to work on a goal, but they themselves won't eat the food they want us to ask the child to
Yes.
eat. And I'm like, oh, but should we still work on this if you don't naturally eat this in the home? But it's the
Yeah.
reality of, and they're like, well, the doctor said we should have this many fruits and
Yes.
vegetables. And I'm like, yes, but that recommendation balanced with what's in your daily routine. Let's
Yes.
go back to how are we originating these goals? How do y'all pick out which goals to work on? What is your um, triage list for goal writing?
Yeah. Well, we start with some of the things that you've been talking about in terms of we want to understand what is the person's routine, what is the
Yeah.
psychosocial impact
Yes.
of the feeding related concerns. So we're really looking at reducing impact. So we want to create physical health and safety. So we start there, goals relating to physical health and safety, which might be supplementation rather than food. And then we look at psychosocial impact. So, if families need to travel overseas and they need to be able to have a variety in the diet, that means their child can eat when they're overseas as well as when they're at home, then we would address that. Or some of our adult clients, they might want to go to a work function and be able to eat the food that is present. So, we might look at that. Or kids might want to be able to go to school camp and be able to participate without taking their own food, or go to a birthday party and be able to eat birthday party food. So we usually start with psychosocial impact after physical health and safety, and look at, well, what do you need to be able to eat in order to participate in your life in the way that you want to? Because it's not just about creating this kind of perfect healthy diet, right? It's about creating a diet that works for them, as you said, in their daily life and their day-to-day functioning. And it's not so much about how many vegetables you have. um, we're very pro like lifelong supplementation if that's what people need. So you don't have to get all of your nutrients from food. It's okay. But we do want you to maximize your opportunities for participation in life in the best way that you can, and reduce the repeated traumas. If something is traumatic and it's not going to be less traumatic, just take a tablet and supplement. You don't have to eat that food. Like, that doesn't have to be a goal.
It's choosing joy.
Yes,
If I have my tiny human and I do my eval as the silo SLP in our clinic, because I'm the only one in the clinic that I work at right now that does feeding, right? Um, I have to refer out to get to an interdisciplinary team, which is the unfortunate reality for a lot of SLPs across the
yes,
country. It's not
absolutely.
ideal, and I know that, but how do I build my network? How do I find a psychologist that actually works on that? Because I got to be honest, like I'll scour the internet and I might find the eating disorders clinic at the nearby
Yeah.
university, but aside from that, I don't know what I'm looking for.
Yeah. In some regard, you might not find a psychologist that works specifically in feeding.
Boo!
I mean, you
Yeah,
might, you
yeah.
might. You might be able to look at some things like, some of the particular models of treatment have listings of people who have completed their training. So, SOS, for example, they have a listing. You can go on their website and look up clinicians that are trained in SOS. So, people who have trained in SOS, like I've trained in SOS, they might not be using SOS all the time or doing full SOS. But it shows they have an interest in feeding. So,
Yeah.
that might be a good place to start. Or looking at if there are other models or places where they have listings of professionals who have done training in their space. I'm not sure if I think Feeding Matters has a directory too, right?
Eating
Um,
Matters has a directory, so you can check that out.
yes,
And you can type in zip code or like state, and then that'll
yes.
help triage. Yep.
So one place is to try some of these listings. I would say also if there are groups in Australia, for example, we have something called the Mental Health Professionals Network. Like there are some of these groups that are designed to help you network with other professionals. Joining groups that are focused on feeding, or where you can kind of meet other people that might be interested in feeding, could be useful. But if you can't find a feeding specific practitioner, what I would suggest that you do is find a psychologist who has expertise in neurodiversity, in OCD, in eating disorders more generally, in some of these other kind of adjacent areas.
That's
And
brilliant. I never thought of that.
ask them whether or not they're willing to do co-work. They might not need to do feeding specific work with your client. Some of what our psychologists are doing in our clinic are more like broad anxiety work, while the speechy does the really specific feeding work. Or they might do kind of safety and trauma stabilization work while somebody else does the specific feeding work.
What
Or
is this
if
phrase you use? Trauma stabilization?
trauma stabilization.
What does
It's
that
like the
mean?
phase one of trauma treatment. It it's how you create safety before doing any kind of trauma processing. It's a specific phase of trauma intervention in psychological work. You look at things like sleep and eating. Like there's a bunch of things that you look at to make sure the person is safe and stable before you do any other work around trauma. So you could look at a trauma expert. So you can draw on some of these other kind of areas of expertise, um, especially if you have the expertise in feeding, and then you can collaborate together around how the psychologists work can support the feeding work that you're doing. Similar to what I said before about an OT, they might not have the feeding expertise, but if they understand the sensory processing elements, which many pediatric OTs would work in sensory processing, you can
Yeah.
collaborate on what parts of the sensory processing are going to support the feeding work that you're doing. Or if your client has underlying OCD, which is one of the conditions that tends to co-occur with ARFID, for example, then you could get an OCD specialist in as a psychologist and collaborate with them around how they can apply the OCD principles in supporting kind of the feeding work that you're doing. So I don't think they have to be a feeding specialist.
That's okay. I've done this a long time and you're the first person to connect these dots. So I feel like we need like a megaphone for this particular moment because in retrospect, that's so obvious. Like, duh, Michelle, but like it never, you gave me hope.
I'm glad. And I mean, that's really what happened to me, right? I didn't know anything about feeding. I was an eating disorder specialist. We don't use that word in Australia, but like we're not supposed to use the word specialist. I had expertise and interest in eating disorders. And then I pivoted, I suppose, into feeding out of necessity because I had clients that needed that work.
Yes.
And so I think health professionals can bring the parts of the expertise that they do have, and you can bring the feeding expertise that you have, and we can work effectively together to support the holistic needs of the client.
Yes. But it ties all the way back into it's a team. And so you have to
Yeah.
work as a team. I'm just thinking of the different departments I need to start looking at tomorrow. Um, yeah. There was Evelyn Trammell Voice Institute down in MUSC, Medical University of South Carolina. They also have an eating disorders clinic that they worked closely with. And it was a beautiful, smooth transition for that state to send down there. But here in Virginia, there's fewer even eating disorders clinics. But I do know that the local university does have OCD support.
And then
Now,
just ask them, are they willing to learn
yeah,
about, like, if you can build a network with people that you work with regularly, they will learn from you and they will learn from their clients and you will
yeah.
learn from them. And it creates that interdisciplinary learning just by having frequent exposure to each other and working collaboratively, even if you're distant from a physical location perspective.
So, folks, if you're listening to this, not all of us had the luxury of doing trainings where we were taught how to engage in interprofessional practice. I am quick to call and ask for the nurse, ask for the referral
Yeah,
coordinator. It was terrifying for me to ask for the physician or the specialist. So I started with the nurse, and it gave me a safe space to start and to practice. Um,
great.
do you have other recommendations for other SLPs that have social anxiety that need, which is ironic because we're SLPs, but like que sera. But what tips do you have for that?
Yeah, that's a good question. I mean, I just leveraged the fact that I'm a doctor. You say you say on the phone, you say, "Oh, it's Dr. Talbot calling," and and they don't know I'm not a doctor, like a GP. So they just put me straight through, which is fantastic.
Okay, so what you're really saying is that I need to figure out how to get my PhD or a
Yeah,
doctorate. Yes.
but in all seriousness, I think um, the majority. I guess my advice would be the majority of people actually do want to collaborate with you,
Yes.
um, and so this is one of the things I think I learned as a very early career practitioner. Um, and it's the advice I often give to when I go to early career seminars and things like that. Um, just contact people. We assume that they might not like you, right? You just reached out to me and now look where we are. You don't know what the outcome will be, but like sometimes the outcome is yes. And
Yes.
that has been my experience generally as well. Sometimes, yes, you might get no response or nothing might come of it, but sometimes you will get a yes, and sometimes surprisingly, you will get a yes. I've reached out to people that are very prominent in their profession, and they've written straight back, and I've been quite surprised. And sometimes that's led to great collaborations and great opportunities to learn from them. So um, I think my feedback would be, remember that those people might also feel like you, and actually it's about offering an invitation, and it's up to the other person whether they accept that invitation or not. You can't control that, but you can send out a lot of invites, and see who's interested in connecting with you. And really, those are the people you want to be working with for your clients, because you want people who are going to liaise with you regularly and who are going to communicate with you, where they're going to be aligned in their approach to wanting to engage in interdisciplinary care. And so if they're not responding, they're probably not the right people to be building your team with to support your clients.
That's so optimistic. I am so grateful to have heard you last month, um, and again today. So thank you for leading with grace and compassion, because you clearly have compassion for those that you serve and the
Thank you.
like their families. But so thank you. If somebody is listening, and they want to learn more from you, is there a website or a resource that they can go and learn from?
Yes, absolutely. So I'm located at the Talbot Centre. Uh, Talbot is spelt Talbot, and centre is spelt the Australian way, Centre. So if you Google the Talbot Centre, that's our website. You can find our socials there as well. You can connect with me. You can look me up on LinkedIn. I'm there too. So just like I said, send me an invite. Be happy to connect with you. Happy to chat with you.
If somebody's listening and they have extra mad money or a little bit of love money, and there's somebody or an organization that you would like to support, where could they donate to?
Yeah, I've been thinking about this. I think probably the best place would be the Butterfly Foundation. So, the Butterfly Foundation is an Australian not for profit charity organization that provides support to um, individuals with eating disorders, and nationwide education about individuals with eating disorders. They've done some work in the ARFID space. So, I think they could be a good option.
Folks, if you're listening, it's butterfly.org.au, and you can find them on all of the socials. Thank you for sharing that. Um, Amy, thank you so much for coming on. Thank you for the spirit of yes and making a safe space.
Thank you so much for having me. It's been a pleasure. I feel like we could talk for hours and hours and hours. It's wonderful to meet other people who are really passionate about the work that we do, and to be able to do that all across the world, given the value of technology, that we can meet together, me in the past and you in the future, to have a chat, and share our wisdom and continue to learn from each other, from different disciplines.
Ah, well, thank you.